Hi everyone, and welcome to the fourth talk on my book, Second Class Citizens, and Issues of Disability and Social Policy. Last time, we considered the origins and purpose of the welfare state, concluding by noting that the original welfare state had left out a major group of people, the chronically sick and disabled. This did not go unnoticed by disabled people and their families, and a number of excellent charities were set up to fight for the rights of disabled people, including Mind, MenCap, Leonard Cheshire, and what is now called Scope. The campaigning of disability charities led to the creation of the first sickness and disability benefits and of social care, which are the subject of this talk. In the initial national insurance scheme, those out of work due to sickness received the same amount of benefit as the unemployment, a level which was predicated on short-term unemployment, and even then had underestimated the costs of short-term basics. No formal recognition was made of the additional problems caused by long-term illness or disability relative to short periods of illness or unemployment. Some disabled people, such as those injured in the line of work or in war, could claim compensatory benefits, but the majority could not. Unemployment benefit, inadequate for short-term physical needs, was even less adequate for supporting people who could not expect to return to work. The distinction between short and long-term sickness was first formalised in 1971 by the introduction of invalidity benefit for sickness lasting longer than 6 months. The benefit was claimed on the basis of a medical note or certificate from a person's GP confirming their incapacity for work. Contrary to Beveridge, age-related top-ups were quickly introduced, meaning that an older sick person got more benefits purely for being older. In Beveridge's original plan for Social Security, benefits would have been paid out at a flat rate. They would have been a little more than what was needed to get by in society. Beveridge hadn't advocated for a long-term benefit rate because in his society there was no such thing as long-term unemployment. The commitment of the government to full employment meant that anyone who was out of work and looking for work was very likely to get work very quickly. But if he had, we might have expected him to set long-term benefits at the same level as the old age pension, or at a level known to be adequate for participation in society. What Beveridge was firmly against was the idea of age-related or earnings-related top-ups. He was convinced of the appropriateness of flat-rate benefits, so that everyone received from the state the same support in the same time of need. He considered that the state should not give luxurious levels of income to those who had become employed from a high-wage job. Such people could rely on the state for enough to live on, just as other workers could, but if they wanted to enjoy a higher level of living than necessary, then they should fund it themselves, perhaps through savings or private income insurance, rather than expect the government to provide that for them. Similarly, people should not receive a higher social security payment just because they were older. As well as being unfair, this overlooked the opportunity these people had had to save for themselves compared to younger people. As well as breaching Beveridge's principle of equal benefits, invalidity benefit also fails to meet the criterion of universal availability. This, however, stemmed in large part from Beveridge's framing of Social Security on the principle of national insurance, which meant that those who had not been able to pay national insurance were inevitably excluded. Although he said that Social Security should guarantee everyone an income sufficient for his subsistence and that of his family when, for any reason, of sickness, accident, old age or unemployment, he cannot work, Beveridge made the same mistakes that have persisted for decades. To neglect to allow adult children and wives of workers to claim sickness benefit on the basis of their father's or husband's contributions, and to neglect to consider that a person's contributions via paid work might occur after, rather than before, the need for and receipt of Social Security. He also neglected the consideration that some people never can contribute via national insurance, but still need to be supported. For people with sickness or disability, this was particularly problematic, because sickness or disability can easily arise prior to adulthood, and so prevent a person from ever having had the opportunity to insure themselves against it. So to provide for people who had not been able to make national insurance contributions before becoming ill or disabled, a non-contributory invalidity pension was established in 1975. The new benefit was primarily for those whose illness or disability started during childhood or adolescence. married women were specifically excluded from this pension on the grounds that they would have been at home anyway, regardless of their capacity for work. A non-contributory benefit was added in 1977 for married women who could not carry out housework themselves, in recognition that this work would then have to be done by someone else. But this household duties test for the housewife's non-contributory invalidity pension was deemed to be so harsh that it essentially discriminated against women. In effect, women had to pass a harsher test of invalidity than did men. They had to be assessed as both unable to work and unable to carry out household tasks. Yet 2 in 5 of those who receive benefits because they are too sick or disabled to work do not receive benefits for being disabled at home. The two are different things. Significant disquiet with the pension, as voiced by disabled people and their organisations, led to the development of a new benefit introduced in 1984, which replaced both of the non-contributory pensions. However, the changes made to the assessment criteria did not materially improve the eligibility of married women for sickness benefit. It was felt that the new benefit simply rendered the discrimination against married women less overt, whilst doing nothing to actually address it. Overall, the piecemeal and reactive development of sickness benefits up to the end of the 1980s resulted in what the researchers Walker and Walker described as an incoherent mixture of benefits which do not mesh together easily, overlapping considerably for some groups, while missing out others altogether. The ideal system that provided universal protection for income loss due to illness or disability had not been fully realised. Benefits were still based on criteria other than need, such as sex or the reason for an illness or injury, when the Beveridge report had specifically advised against this. The result was that instead of payouts being consistent across people with similar levels of functional incapacity, there were a variety of benefits being paid based upon extraneous factors such as the reason for illness or injury, or the age or sex of the person concerned. Not everyone who needed it could get support, and those who did get support did not receive enough to compensate for their disability and place them on an equal footing in society with the non-disabled. The 1970s also saw the introduction of first extra costs benefits. Prior to the welfare state, many disability-related benefits were compensation-based. They were intended to compensate someone for an injury or impairment incurred in a line of work, and in many cases this required proving not just that harm had occurred, but that the employer was at fault. They therefore failed to cover disability from injury when no one's behaviour was at fault, or where the employer was at fault but it couldn't be proved. The welfare state introduced the insurance principle, in which neither fault nor cause had to be identified, but this did require that someone have the opportunity to pay in before receiving support. And both compensation and insurance-based payments missed a key issue, that people with disabilities not only have lower incomes, they also have higher expenditures. The new extra cost benefits were therefore designed with the intention of improving disabled people's footing in relation to non-disabled people by covering some of the extra costs that disabled people face. Attendance allowance was introduced in 1971 following a survey which showed that disabled people experienced widespread extra costs as a consequence of their disability. Attendance allowance covered disabled people for the extra costs incurred in their home, and was paid at 2 rates depending upon the amount of assistance needed for specific home-based activities, such as washing and dressing. 4 years later, in 1975, mobility allowance was introduced to cover some of the costs associated with the difficulty of getting around. However, mobility allowance excluded people over 65, on the grounds that older people often have mobility needs, so this isn't an extra cost, but just part of normal life. But this conflates age with disability, an anachronism which is increasingly inappropriate as life expectancy and disability-free life expectancy increases. Nevertheless, despite the opportunity to rectify this when creating new extra cost benefits in 1992 and again in 2012, the Conservative Party has not brought extra cost benefits into the modern era. Consider the case of Fiona, who was born with the hereditary condition retinoblastoma bilateral and had to have both her eyes removed before she was 2 years old. Fiona can't see if her clothes are dirty or stained, so either has to risk going out in unclean clothes or wash her clothes more frequently than is strictly necessary. This adds not just extra laundry bills, but also means that clothes wear out faster and therefore have to be replaced more frequently. Fiona also can't see to mend small tears or holes in her clothes, and either has to pay someone else to repair them or pay to replace them completely. Despite being classic examples of some of the extra costs that sick and disabled people face, Fiona's higher clothing and utilities bills aren't now, and never have been, considered in extra cost benefits. As with the original formulation of Social Security, these benefits have been heavily influenced by the historical understanding of a household consisting of a man, his wife, and their children, in which the man goes out to work and the wife works at home. A tribunal judge ruled that the ability to perform domestic tasks was not to be included in assessments for extra cost benefits, because these were tasks that a wife or daughter carries out as opposed to the disabled person himself. And despite claiming, in both 1992 and 2012, to need to bring extra cost benefits into the modern era, the Conservatives have not corrected this anachronism. The ability to carry out domestic chores, and the additional utilities costs associated with being at home or managing disability, therefore continue to be ignored. The 1971 invalidity benefit and attendance allowance came in around the time that campaigning by disabled people themselves, rather than their families and associated charities, were really coming into their own. One of the earliest themes of the New Disability campaign movement was the right to independent living. Independent living could mean a variety of different things, but at its core are always the concepts of individual choice, control, freedom, and equality. It is the right we all have to build a life of our own, with family, friends, and neighbours, enjoying the same housing and other social rights that everyone else should be able to enjoy. Disabled people should be able to choose where they live, and when and from whom they receive any assistance they need, with the same level of choice and control as non-disabled people. And they should have the same opportunity to take part in work, leisure, and family life as easily and fully as anyone else. But in the 1970s, the legacy of Victorian public asylums was still present in the form of large, dehumanising residential institutions. These had been intended as places of refuge, moving the work of care from unpaid families and the church to paid staff. But a brief period of good ventilation and extensive gardens had collapsed under the sheer numbers of people in need, and saw a return to physical and drug-induced restraint of residents. Irving Goffman, one of the most influential sociologists of the 20th century, spoke of these institutions as social arrangements that regulate according to one rational plan and under one roof all spheres of individuals' lives, working, playing, eating, and sleeping. A standard routine included getting up at 6:30 a.m. and going back to bed by 7:15 p.m, with food available only at prescribed times. Prudhoe Hospital was one of the better institutions, but strong suits were still in use to restrain patients, and low staffing levels meant that many patients were drugged to keep them quiet. Family visits were confined to 1 day a month. Kay, a resident in Prudhoe, described a typical mealtime. The staff feeding them by holding their noses, that's not right. I was trying to speak up for the people in wheelchairs. They dragged me out, took me back, and doped me. I was just speaking up for the people in wheelchairs. They shouldn't get fed by their noses, it's wrong. Another resident, Metallica, reported that the staff were very strict. When I was in Prudhoe Hospital, staff put them to sleep to control their temper. I remember an awful lot of people who got injections. The governments of the 1980s responded to this campaigning with a renewed commitment to end institutional care and bring in care in the community. The main focus was to allow disabled people to live and receive care in homes. New residential and group homes, which were on a smaller scale and provided individual bedrooms rather than multi-bed wards, were created, and the provision of daycare expanded. However, the full shift to disabled people, particularly those with mental illnesses or learning disabilities, actually living in their own homes had not been made. Essentially, all that happened was a downscaling in institution size. Many others lived with their parents rather than in their own home, with the attendant fears of what happens when their parents have passed away. An audit in 1986 found a number of problems with the movement from institutional to community care. The change in responsibility from hospitals and health systems to local government and social care systems had not included an adequate financial shift. Responsibility for the implementation of policy had been fragmented, and consequently the shift of resources and personnel was slow. Without a comprehensive framework for planning the transition of disabled people between institutions and community care, the actual delivery on the ground was quite poor. In particular, the Community Care Initiative had not properly listened to disabled people and what they had to say about their needs and abilities, and the forms of support they wanted. Altogether, the policy goal was desirable, but underfunded and inadequately thought through. And as with the sickness and disability benefits, despite noises to the contrary and some attempts to make changes for the better, the same anachronistic views prevail today, with the same flawed approaches to care resulted in the same damaging and abusive practices. In response to an audit of community care, the British Council of Organisations of Disabled People summed up the state of disability policy up to the late 1980s. Existing policies do conflict and often appear irrational to disabled people who have to live by them. In the opinion of the British Council, this confusion cannot but be so because existing policies and practices have been based in incomplete and inadequate information. This has come about because of the long historical exclusion of disabled people from mainstream social life in general, and from policy development in particular. Public policy in this field has been dominated by non-disabled perception of our problems, which can only yield a limited view of their solutions. The information which is derived from direct experience has been systematically limited or excluded from the decision-making process. Attempts to correct this have been desultory both on paper and in practice. That was in the 1980s, and frankly things aren't any better now. Governments still fail to listen to the people affected by their policy, and they still use flawed perceptions of reality when they make their policy. The next 3 talks are going to be about these flawed perceptions across economics and behaviour.